Good morning to everyone on the West Coast, and good afternoon to those on the East Coast and everywhere in between. Welcome to our January 26, 2016 webinar, Implementing Early Psychosis Interventions in the Real World. I'm John Osowski, Dissemination Manager for Pathways RTC, and I'd like to begin with a few housekeeping announcements. Please see the advice on this slide to make the most of your GoToMeeting experience. In particular, please note that during the presentation, all audience members will be muted, but you can send your questions to us via the chat feature. A recording of this webinar will be available online shortly after the webinar ends at the link that you see below, and we'll be repeating this link again at the end. And we'd like to invite everyone who's registered for this webinar to stay in touch with us by signing up for our monthly newsletter, the RTC Updates. We feature links to resources like this webinar, as well as news and events of interest to the field. You'll receive an invitation email after the webinar, and we hope that you choose to accept it. Signing up on your own is also very simple. You can just go to our home page, www.pathwaysrtc.pdx.edu, and click on the RTC Updates button, which is located where the orange arrow is showing. Future webinars are always announced in our newsletter, and attendees today will be getting a sneak peek at next month's offering. So that sneak peek is, please save the date, Wednesday, February 24th at 10 a.m. Pathways Project SPAC, System, Policy, Analysis, and Change, will present Stepping Up, Young Adult Voice and Policy Change. You can register through the link that you see below, and we'll include a registration link in our next newsletter. This webinar is brought to you by the National Training and Technical Assistance Center for Child, Youth, and Family Mental Health, NTAC, operated by the National Technical Assistance Network for Children's Behavioral Health, the TA Network, funded by the Substance Abuse and Mental Health Services Administration, SAMHSA, Center for Mental Health Services, Child, Adolescent, and Family Branch, and we're very thankful for that funding. So on to today's webinar. Welcome. Implementing Early Psychosis in the Real World. I'd like to introduce our presenters today. Tamara, who is the Director for the Early Assessment and Support Alliance EASA Center for Excellence, and Dr. Ryan Melton, Clinical Training Director for the EASA Center for Excellence. And I'd be remiss at this point if I didn't mention that Ryan and Tamara are co-editing this year's edition of Focal Point. Focal Point is a publication of Pathways RTC devoted to youth, young adults, and mental health. This year's edition is focused on early psychosis intervention and is due out in the late spring, so please keep in touch with us for that. And without any further ado, Ryan and Tamara, would you like to take it away?
Yeah. Hello, everybody. We're really excited to be with you today, and we have a lot to cover in a very short time. So please feel free to send questions, and we'll try to follow up with folks. Ryan and I have been involved since 2001 with implementing the first early psychosis rollout in the public mental health system in the United States. So we started with 5 counties in 2001, and then starting in 2007, we began the statewide process in Oregon. My role all along has been to coordinate that effort, and that role just continues to evolve over time. Ryan, would you like to introduce yourself?
Sure, as introduced already, so I'm Dr. Ryan Melton. I'm the Clinical Director for the EASA Center for Excellence. If people were confused which one of us is which in the picture, I'm the one with the facial hair. Yes, so my role primarily with the Center for Excellence is to provide clinical training for the EASA staff around the state of Oregon. I also do some national training as well, really kind of focus on the clinical aspects of the program. Happy to have you all.
Great. And so I should mention that the bricks behind Ryan are from the Rupp Arena in Kentucky. So we just got back from the snowstorm in Kentucky and had a wonderful time with folks there. So the EASA Center for Excellence that John mentioned was created in 2013 at Portland State University. And as he mentioned, we're connected now to a whole national technical assistance effort. And we'll be talking more about that as we go on. This is just a picture of our website, easacommunity.org. We have lots of resources on there that we've created for people and continue to develop it, as well as our Facebook page, which we encourage everyone to like. And my email address, of course, is there as well, so feel free to follow up with questions. So today we're going to give some context and history around early psychosis intervention. We'll cover the core practices of early psychosis intervention, and we'll talk about some of the challenges that people commonly run into as they try to implement these programs, as well as some strategies that we've identified that seem to be effective. And then we'll provide a bunch of different resources for folks to continue learning and collaborating.
And then to engage all of you and to figure out more about what your agenda would be in attending today's webinar, we'd like to launch a quick poll. And this poll is about your role in your work. So hopefully you all see that. And the voting is going on. And we'll give you just a few more seconds to chime in and let us know. All right, you see we have a majority vote so far, but to make it truly democratic, let's keep going. Yeah. All right. Okay.
So it looks like we have about a third of the folks on the call are clinicians, and then about another third are administrators either at the state or local level, and a good number of clinical supervisors and advocates as well. So it's a good mix of people.
Yeah, so let's just close this poll and share the results with everyone so they can see as well. And that's exactly what Tamara was mentioning. All right. So hopefully that will be able to address the individual concerns of folks on this webinar. All right. And we're ready to move on.
Okay. Great. So we wanted to start off talking a little bit about schizophrenia, because most early psychosis programs focus specifically on schizophrenia, and that'll be one of the early decisions that programs have to make, is whether they're going to limit their focus to schizophrenia or try to have a broader focus. But I did want to address why we talk so much about schizophrenia. There's all kinds of research demonstrating the tremendous impact of this condition, starting with the fact that we're spending many billions of dollars per year on care and lost productivity. It's one of the leading causes of disability for the age group of 15 to 44. Folks are dying earlier. 10 years is a conservative number. The numbers go up to 25 years earlier. People are at much greater risk of suicide, and often those suicides happen very early on when the illness has begun. And of course, we also know that people end up being hospitalized multiple times. They have quite a bit of legal involvement. And then unemployment rates higher than 80%. People often end up as victims of violence. We know it impacts homelessness. So those are a lot of really painful statistics that we try not to dwell on, but it definitely gives us a good sense of the urgency of this conversation. And that urgency is contributed to by the fact that the conditions tends to start when people are teenagers or young adults. There's a very large body of research now about what works with this kind of condition, and that early intervention can have a significant impact on people's long-term functional outcomes. Okay. One of the things we talk about a lot in early psychosis intervention is the fact that people are having significant delays in accessing care. And those delays can be attributed to a range of things, starting with the fact that the symptoms are difficult to recognize in the beginning. People don't necessarily have the education about what to look for. People may be reluctant to seek care for a variety of reasons. Our organizations tend not to do a lot of outreach. And then we've created numerous barriers, ranging from insurance requirements to requirements that people be motivated for treatment. And then finally, the care that we do have available tends to be based on what we've kind of cobbled together from our existing funding systems, and not so much based on what we know is effective. You'll hear a lot about the term duration of untreated psychosis, or DUP, so it's important that you know what that means. The Birchwood came up with the concept of a critical window a while back, which is the idea that there's an early period of about 3 to 5 years, and depending on the level of disability or functioning that people get to during that time period, that tends to kind of set the trajectory for their long-term well-being. We know that the average duration of untreated psychosis, so the average time between when people develop psychosis and when they receive care, is between 1 to 2 years. And the RAISE study that just came out found an average of 74 weeks. There's lots of research, again, that shows that that kind of delay, particularly past the 2 to 3 month mark, it really significantly impacts symptom severity, rates of remission, social functioning, and quality of life. And that impact can persist for many years to come. One of the most important findings, I think, of the RAISE study was that there was a relationship between DUP and the outcomes in that study. We're all joining a thriving international community that's been going on since the 90s. When we began in 2001, the folks who trained us were the Early Psychosis Prevention and Intervention Center in Melbourne, Australia. At that point in time, the TIPS and OPUS studies were going in Scandinavia, and those have become kind of long-term studies where there's lots of great research coming out of them. There's the International Early Psychosis Association, which we encourage everyone to join. There's a wonderful conference coming up in Milan, Italy, for those of you who are rich. But it's really a wonderful and very generous group of folks. And that international work has led to national dissemination in most of the Commonwealth countries, particularly Australia, New Zealand, England, and Canada. There's also a fair amount going on in Germany and Singapore and some other places around the country. But we were very fortunate early on to have these teachers from outside of the country. But also within the country, at the time that we started in 2001, there were numerous university-based research programs where their research hadn't necessarily been translated to the community yet. And I particularly want to mention the North American Prodromal Longitudinal Study, which is a network of universities across the United States and Canada that have been pooling their data for a number of years, looking at the onset process for schizophrenia, and really trying to understand how we can detect the illness at the very early stages. And they've made some very significant progress, and we'll definitely be hearing from them in the near future. Also, some of the other key players that were around at the time that we started were John Kane's group at Hillside Hospital in New York, the University of North Carolina OASIS program, which has done some really wonderful work, and we have a lot to learn from them. UCLA, a bunch of programs in the University of California, campuses across California. Yale, of course, has been kind of a forerunner in this field. And then, of course, we started in 2001. Initially, we started just with First Episode, but then in 2010, we expanded at a statewide level to psychosis risk syndrome. The PEER program in Portland, Maine also started right about the same time in 2001, focused specifically on psychosis risk syndrome, and then they added very early First Episode in 2007 with the EDIP study, or the Early Detection and Intervention for the Prevention of Psychosis program that was funded by the Robert Wood Johnson Foundation. And so we were also part of that study. And that particular model used multifamily psychoeducation, ACT, and supported employment and education. So the results of that study are out, along with the one that probably everyone has heard about by now, which is the RAISE Early Treatment Program, also known as Navigate. That was a randomized controlled trial across multiple sites around the United States, and they found some significant differences with using a manualized treatment. And then the RAISE Connections Program, also known as On Track New York or On Track USA, which was designed primarily to help with the dissemination process. So both of these two programs have generated significant public domain materials that our programs across the country can just basically pick up and use, although training is obviously important as well. And we'll talk more about how to get access to all these resources. It's important to mention recent congressional action. So in 2014, Congress increased the mental health block grant and required states to set aside 5% for early intervention for serious mental illness, including psychosis. And then just recently, in the Consolidated Appropriations Act of 2016, they increased that amount to 10%, along with increasing the dollar amount available. So that has led to a great deal of new programming around the country. There's been a lot of funding through SAMHSA and elsewhere, NIMH in particular, leading to many, many technical assistance materials, as well as technical assistance, including this webinar. And then the Prodrome and Early Psychosis Prevention Network, or PEPNet, was created in 2014. That is the first early psychosis network in the United States, and they are accepting members. So that's a great resource for all of us. Partners for Strong Minds was also created about the same time. That's a national organization focused on trying to educate the country around these issues. And of course, the number of programs is just growing almost exponentially. I think we started out with 16 in 2014, and now we're well over 100.
Wow.
Yeah.
All right, great. Well, before we continue on, and I guess Ryan is going to be leading off this part, let's do one more poll because it seems to be germane to the conversation. And this poll will ask about where you're at with your level of intervention at this point. So if folks would just take a few seconds to vote here. We won't keep it open for too long. Results are starting to come in. Okay. This is interesting. So we'll just have another 5 seconds. All right, and we've got about 3/4 of everyone voted, so we're just going to close the poll and share it with you now. And you can see the results. Looks like we've got almost a tie between beginning to think about it and already started. So with that, let's turn it over to Ryan.
So I get to talk about what these programs actually do. So what are the components that make up early psychosis program or coordinated specialty care for early psychosis programs? I think most of the experts in the field agree these are the primary components, although certain programs vary in to the extent to which specific interventions they're actually implementing, but majority carry these programs, which includes support employment and education, some clinical work, and a variety of disciplines that make up the clinical work: counselors, psychologists, nurses, recovery coaches, which most programs will refer to as case managers, peer support specialists, occupational therapists, medical prescribers, whether that be psychiatrist, psychiatric nurse practitioner, in some cases even PAs. We certainly need somebody kind of leading these programs, whether that's a designated team lead or a clinical supervisor. And within all of these roles, we like to support a shared caseload, meaning that there's no one person that really owns the case, for lack of a better word, that it's really a shared responsibility across disciplines, even sharing goals and sharing the workload. A frequent review of clients in which that all team gets together at least once a week, if not more frequently, to cover every discipline and every client. And then really focusing a participatory or shared decision-making framework where the individual participants in the families or their support systems are active decision makers in what treatment they receive. Okay, next. So these are the specific strategies. Just in a little bit more details of what makes up some of the counseling, coaching, and that's going to involve motivational interviewing strategies for some of the reasons that Tamara mentioned earlier, maybe a lack of motivation, a lack of insight, for lack of a better word. Cognitive behavioral therapy, specifically for psychosis, is a very nice evidence-based to be effective with individuals both in a psychosis risk syndrome as well as early first episode. Family psychoeducation and individual psychoeducation, a good evidence-based strategy that's commonly used in these programs. A lot of programs use Bill McFarland's multifamily group models. Others use other family models. One clear component of several of these programs is the integration of supported employment and supported education. The primary model used with supported employment education is the individual placement and support model, or the IPS model. Supported education in particular still is developing an evidence base, and we're still trying to look at what the model looks like for this particular group, but that's in development. Regardless, that would be encouraged, if not in some ways mandatory, for your early psychosis programs. Peer support is an emerging model in these programs, seeing more and more programs across the country that are integrating peer support, so that would be individuals with lived experience that are supporting the teams. These programs really don't work if you're not reaching out to the individuals in their homes or other places of interest, particularly to engage those whose condition is limiting their insight into the need for treatment. We have to go to them. We have to accommodate for that level of disability. And of course, medical interventions, which is going to, in a lot of cases, if not most cases, involve medications, but medications are done very carefully with true transparency and shared decision-making with the participants and the families. Obviously, starting low, going slow is the standard mantra of early psychosis programs, with considering tapering if there's a period of stability, and in some cases maybe not even using medications, particularly for those who are in the psychosis risk syndrome, and focusing more on psychosocial supports and other wellness activities, which we kind of integrate all into our treatment. Next. Yeah, one thing about, you've heard me use the term evidence-based practices, and obviously these programs are made up of a series of evidence-based practices. I'd like you to consider that evidence-based practices, or at least try to think about evidence-based practices as a verb and not a noun, so that these are not stagnant. They need to be individualized, and in a lot of cases need to be translated to kind of fit the population that you're serving. Many of the evidence-based practices that we use in early psychosis programs their evidence has been established on individuals much older than the group that we are currently seeing in early psychosis programs. So there has to be some developmental modifications to the program. So again, please consider evidence-based practices more of a verb than a noun. So they're always evolving. The intensity in terms of how large caseload sizes are is similar to that of assertive community treatment, generally around 10 to 15 clients or participants for one FTE, and that would be across your entire team. And just given that the team is so specialized, we like to keep as much as we possibly can within the team structure. So that would include like the treatment of substance abuse disorders. We want your team to be trained and prepared to work with that condition as well, versus referring out. Now, if somebody needs obviously a higher level of substance abuse care, such as a residential level of care, then you may want to refer that out. But generally, our recommendation is that be done within your team structure. Okay, next. Yeah, here's some other core functions of coordinated specialty care teams. crisis response planning. That should be done immediately, particularly with your group that's having a first episode of a schizophrenia-related disorder, working with a family, doing some crisis planning. When somebody has had an initial psychotic episode, to engage in relapse prevention. I've heard many experts in the field say one of the primary goals of these early psychosis coordinated specialty care teams is, if one episode has occurred, your job is to prevent another episode from occurring. So prevent the second episode, and one way to do that is engage in relapse prevention planning, and there's a series of models that can be used for that. And obviously continuity of care, and what I think that means is that you're working with a very specific developmental age group, and that developmental age group kind of transcends between late adolescence and adulthood. That means they may start in your program at 17 and then end up and turn 18, so on. So we'd want to see continuity of care versus switching from a child adolescent system to an adult system. We really want these teams to be able to cover the spectrum of development, so they don't have any change in providers when they turn 18 should they come into your program at 17. A good comprehensive assessment, meaning I think one thing that we really want to do with these cares is, with these programs, is to really kind of focus on what is happening with the individual and going above and beyond your kind of standard biopsychosocial interview, using tools like the structured interview for psychosis risk syndromes if you are a psychosis risk program, using a very kind of comprehensive diagnostic system. I know many programs across the country use the SCID, which is a structured clinical interview for DSM disorders. So getting into much more detail, there's so much diagnostic ambiguity with these individuals in the early stages that we want to use the best possible measures and assessments to determine what's happening, so we can have very focused treatment planning and avoid diagnostic errors to the best of our ability. Your ongoing treatment planning should be focused on strengths and resilience of the individuals, basically working with establishing goals from a person's primary strengths and goals versus from pathology. Remember, developmentally, this is a group that isn't going to focus so much on their illness or their symptoms. They're going to be focusing on their future goals, and we want to facilitate that. So all goals should be really directed towards what the individual wants in the future versus reducing some symptoms, because they're generally not going to talk in terms of reducing symptoms, but talk more in obtaining future goals, such as going to work, having a significant other, graduating from school. And then, of course, the majority of the individuals that will enter your programs have involved families. So we would want families, or at least intact social systems, so you would want to continue to keep those families and social systems intact. So you really want to take a systemic approach to working with individuals and their families. Essentially, the families become participants as well, so engaging them in family psychoeducation, crisis planning, relapse prevention, part of the assessment, attending family groups, all of that. They're equal players in terms of a treatment focus. Next slide. Yeah, so again, what are some of the goals? Again, focusing on mastering symptoms, finding meaning, really personal goals, and those personal goals are consistent with one's developmental process. Again, this is a group we know from the Oregon data, around 90+% of our individuals enter our program with school or work goals, so that's going to be a big focus of your coordinated specialty early psychosis team. Talked about this earlier, but starting very low, engaging in very careful prescribing with careful attention to side effects. We know that individuals will probably experience the negative aspects of medicines before they'll experience the good aspects of medicines, and we know a good percentage of these individuals will want to stop their medicine, so paying very close attention to side effects and even tying the medicines back to their personal goals versus a reduction of symptoms. And generally, these programs are short in duration. Some programs are 2 years long, some programs are 5 years long around the country. But throughout the course of your work with these programs, you want to be focusing on what's next for the individual in terms of a transition plan. I know in Oregon, in our guidelines, we have a specific transition guidelines on what we should be thinking about throughout the process to assure that there's a careful transition to ongoing care. And that ongoing care could be anything from, practice as usual, maybe another sort of community treatment program, or it could be nothing. So it would also be very individualized. The point is that you're paying attention to this throughout the process and preparing them for what's next. Okay, next slide.
Great. So we're going to kind of switch gears a little bit and start talking about implementation. There's never been a time like today for implementation, and I just love this quote from the kind of coordinated specialty care white paper, as I refer to it, by Heinz, Goldstein, and Azrin. You have the URL there for downloading it. So this is referring specifically to race, but also the body of evidence. And what they're saying is that these early findings and along with the evidence, is so compelling that the question is not whether early intervention works for first episode psychosis, but how specialty care programs can be implemented in community settings throughout the United States. So there's actually serious discussion about how to make this the standard of practice in every community in the United States right now. And that means that we have systemic support for addressing the kinds of issues that you'll run into as you're trying to implement. So I've identified 4 kind of general categories of implementation challenges that come up over and over again. Learning curve, hiring and keeping the right staff, building the infrastructure and the accountability that you need, and of course financing. So, I think all of us have experienced that the learning curve associated with this is just pretty tremendous. I mean, there is no one who has the entire picture or has been trained comprehensively enough to be fully prepared for this work. So it's very important to try to consolidate staffing as much as you can, to assign an adequate amount of time. In Oregon, we've set an absolute minimum, even for our rural communities, of trying to have at least 0.2 FTE for the lead clinician. And we really shoot for at least 50% and full-time if we can get it, because the learning curve is just so significant for folks. Also, and the same is true at the administrative level in terms of figuring out the logistics around how to make this work. It's really a significant effort. It's been my full-time job for 15 years now, and I've never run out of work. So, fortunately, there are a number of existing resources that can walk you through the process step by step. There's some really good implementation guides out there. There are manuals that take you through the treatment process where you can just pick them up and actually walk through step by step in order to start building the knowledge base that you need. But the bottom line is that it takes time to have this kind of learning. You really do need training. You really do need some form of ongoing consultation. And you can expect that it's going to take your clinicians a couple of years to be fully trained. So, you can try to train everybody completely overnight. That's going to be difficult. What we generally recommend is that you get the basics under your belt, and then you keep looking for what you still need to learn and keep developing your skills. We also encourage states to really think about kind of how they're going to provide ongoing training and ongoing consultation. We have to repeat our core training in Oregon about every 6 months. Of course, we have a statewide process, and we have new clinicians coming on board all the time. So the more that you can enter into train-the-trainer arrangements where you've got your own capacity to do the ongoing training, the more sustainable it's going to be. Hiring and retaining the right staff is absolutely essential, no surprise, right? And one of the things that we found over and over again is that even with the right staff, if they don't have really strong clinical supervision, they're going to struggle. So we'd like to start with clinical supervision. Having somebody who's in it for the long haul, somebody who's knowledgeable, skilled clinician, is really going to go go to bat for folks. In terms of identifying and hiring the right people, we encourage you to include people with lived experience always on hiring committees, as well as decision-making committees where you're defining your roles and looking at what's working and what's not. And I know we have a number of rural communities that really struggle. I think I see it spelled in there. But you know, there's some good strategies around that. You know, we really encourage people to put the word out there to the broader network when you're trying to hire. You know, there's lots of folks looking for jobs out there, new students, you know, new graduates. And if you've got loan repayment available, or if you can make it available, you know, advertise that. You know, also, you know, advertising it as a specific opportunity for clinicians, you know, where you're advertising that it's early psychosis work. You know, we've run into a number of situations where people have just advertised like a generic clinical position, and then the clinician doesn't actually know what they're getting into. And it is such a long-haul investment for them that you lose them pretty quickly. So you want people who are skilled, or at least very, very interested in learning, people who are willing to really invest in it, excited about it, persistent, not going to give up easily, people who actually like teenagers. That is so, so important. And of course, people who are good at working with teams. So, for example, if you're hiring a psychiatrist or recruiting a psychiatrist to come on board, you know, our psychiatrists sometimes will hang their high school diploma on the wall because they are kind of narrowing that gap between the power differential. Another thing that's related to the clinical supervision is that you have to really intentionally look at agency barriers. So, for example, productivity requirements, where you have folks who are engaged in a lot of teamwork, a lot of outreach. That can become a real problem if your employment structures, your review structures are punishing your clinicians for doing the work they're being asked to do. Limitations on flexibility, like outreach or working in the evenings to do a group, that kind of thing. And so again, you know, the senior administration and the clinical supervisors need to be tuned in to these likely challenges that the teams are going to have, and ready to basically make exceptions and to change the way the agency operates. Also, it's helpful for folks to have the opportunity to network with each other, and you know, particularly where we have folks who are just thinking about a new program and people who have already implemented, you know, it creates a great opportunity for us to network across programs. And so, you know, PAPNet is really working on that, as well as you know, in our long-term process, you know, we do a lot of networking. And in particular, looking at opportunities for folks who are bilingual, bicultural to network with each other, folks who are, you know, peer support specialists, as well as supported staff or specialized staff like occupational therapists and supported employment and education specialists. Okay, so on infrastructure and accountability, you know, we have to recognize that this is systemic change. It's not a minor shift. It's a fundamental shift in our paradigm. So that requires a significant amount of leadership. Again, I mentioned train the trainer. And really looking at, you know, how are we going to build a long-term kind of training and evaluation, quality improvement component. Also looking at what are people transitioning into. So you can provide a fantastic array of services, and then you discharge them from service and they find nothing, and all of a sudden they're back in the hospital a week after you've discharged them. So you really have to look at all of those different pieces and think about how to build those in. And then kind of benchmarking, really understanding, okay, well, we might have, you know, 50% rate of hospitalization coming in, or an 80% rate of hospitalization, but, you know, let's see what we can do to reduce that to 60% or 40% or 25%. Mm-hmm. Okay, financing. So, you know, there are lots of opportunities for billing out there. Most of these services can be billed under Medicaid for sure. One of the challenges that you'll run into is that you do run into a lot of private insurance. So that's a discussion at the national level around how do we make parity a reality. There are alternative payment structures that people are pursuing, like bundled payments, case rate structures. You know, and you may have to actually come up with subsidies. So you know, as you look at the federal block grant, basically that's a subsidy. So that should be used not to supplant Medicaid, obviously, but to fill in the gaps. So looking at what can you pay for right now, what can't you pay for, and then how do you use that that block grant money, or maybe a private foundation money, or some kind of ongoing appropriation that you seek from your legislature, just to fill in those gaps while you work to make those gaps no longer gaps. And then one thing that I really encourage you to look at is tying it to the Olmstead decision or other kinds of hospital mandates, because these are folks who are very, very vulnerable to going to the state hospital and also going to jail. So to the degree that you're under legal mandates where there's funding attached to it, you can tie this program directly into that as a strong argument for legislative funding. And of course, you know, continuing to work with insurance regulators and advocacy organizations around insurance parity, which I think is a much broader issue for all of our community mental health centers. But for this age group, it's a tremendous issue. If people are still on their parents' private insurance, it really is problematic for us to force them to go off their parents' insurance and onto public assistance. And so that's part of the national discussion. We are going to be starting an early psychosis learning community funded by the NTAC folks. We're going to have a smaller group that's going to go through a more intensive process where we meet every month, but we also will have elements of it which are open to a much broader network. And so in that process, we'll be going through a self-assessment, kind of walking through what the key information and decisions are, and then providing some networking and learning opportunities, as well as some written technical assistance resources and kind of links to the stuff that's out there. The time frame for it is April through December of this year, and we'll be accepting applications to it. So, you know, if you're interested, you could either just sign up for our listserv and get information, or you could decide to make a greater commitment, at which point we'll be going through an application process. So if you're interested, send us an email, and also we'll be sending out additional information to the listserv about it. Okay. As I mentioned, there are lots of great national resources. I really encourage everybody to join PAPNet. Really also encourage everyone to join the International Early Psychosis Association. Those are free organizations at this stage. The National Association of State Mental Health Program Directors has put quite a bit of resources into developing TA materials and webinars, and those are all available through their portal, which you see on the slide. NAMI National has a national learning community around this. The National Council on Behavioral Health has done its own learning community and has some materials, and Partners for Strong Minds, again, is a really great resource. They have, we have a national directory on our website at EASA, and they also have a national directory on their website. Okay.
And I just wanted to let folks know that, you know, don't worry about scribbling down these URLs really quickly. These slides will be available after the webinar on the Pathways RTC website, so you'll be able to get them from there.
Okay. And then, as I mentioned, both On Track USA and Navigate have all of their manuals, as well as some really great first-person videos available. So there's a link to those. The we have a bunch of different materials on our website, and of course, the EPIC, the Australians and the folks from England, as well as a bunch of Canadian programs, all have resources. And I haven't listed every single one of them here, but everything links to everything else. And the Peer Training Institute as well, which we mentioned, has a link there. And they've got some downloadable materials as well. Okay.
All right, so that more or less wraps up the presentation part. We're doing very well with time. We've got about 14 or so minutes to answer some questions that have come in. So I'm going to turn this over to Tamara to have a look at some of the questions that have come in. If you wouldn't mind picking one and maybe reading it off, and you and Ryan can respond.
So let's see, the first question was about the Consolidated Appropriation Act of 2016 and kind of the status of that. So rather than responding to that, let me actually request that the folks from the federal government respond to it. So what I'll do is I'll follow up with an email to the group about the exact status of that.
Okay.
Okay.
So then folks can find out about that through your website, or
or can we actually send an email to the group?
Yeah. We'll find out who sent this question, and we'll send an email out.
Okay.
We also may be making a Q&A resource that goes along with this webinar that you'd be able to download with the slides.
Right.
So we might be able to include an answer there too.
Okay. And then the second question was, do you recommend long-acting injectables? Again, that's a medical discussion, something that is coming up more and more, and there are definitely, there's some studies that are being done of that. There's some folks who are definitely leaning towards it. So I think that's probably going to be one of the things that we add to our list to bring the medical folks into. And then in terms of, there's a question about would we be willing to share our transition guidelines. Absolutely. Our practice guidelines are on our website under resources for professionals. And so, our transition guidelines for transition out of care are part of those practice guidelines. And we'd be happy to talk further about how we use those. And then the question about, is there a trauma assessment? I know some of the programs do have specific trauma assessment tools that they use. So, this is one that we can run past the PEPNet group and, see exactly what people are using. Ryan, do you want to talk a little bit about the assessment of trauma?
Sure, yeah, I think I don't know if programs are using a specific trauma assessment. I think that's very individualized. I definitely know programs are using and integrating trauma. It's one of those things that we are assessing with every individual. But I'm not familiar with programs using, say, a specific checklist or a specific trauma-based assessment other than your kind of broad diagnostic assessment like the SCID, which does have a trauma module, and I know that several programs are using that.
And we do have some additional questions that are filtering in.
I did just, John, I posted the link to our practice guidelines in the chat box. I don't know if people are able to see that or not, so they can link directly to our practice guidelines. That's a direct response to the person who asked about the transition checklist.
Okay, great. I see that. I'll send it to the entire audience because I think you shared it with us. Mm-hmm. So I'll just, oops, cannot seem to make the copy and paste feature here work. So while I fiddle with this, maybe Tamara can take on some of these other questions that have come in.
Okay. All right. So let's see. Here's a good one for Ryan. How can we distinguish between a psychotic disorder versus a different disorder such as depression with psychotic features? We actually do a fairly extensive training on exactly this question, and it is important for everyone to get trained on differential diagnosis. You want to talk a little bit about that, Ryan?
Sure. There's not a short answer to that question. Obviously, I'm happy to, if that person wants to email me directly at rymelton@pdx.edu. I don't know, John, if you can send that out. I'm happy to talk to them and go a little bit more detail, but I do have some tips on distinguishing between those two conditions.
Yeah, and we can also, if we run out of time here, we can respond to people offline as well, because the system does log who's asking the question. So yes, definitely, Ryan. And for anyone else out there that has a question that we might not get to, have no fear. We will follow up with you in some way.
Yeah.
So I feel bad. I mean, I think it's a more complicated response than what I can probably answer in 5 minutes. But I definitely want to respond to it because I think it's a really important distinction.
Great. Great.
Yeah. Good resources for certified peer specialists on young adult teams. Again, this is an area where there's a lot of program development going on nationally, and we can send out some good resources for folks. I know Youth Move has been doing a lot of training nationally with teams, and they're a really great resource. There's some webinars on the National Association of State Mental Health Program Directors website specifically focused on this topic, and there's also a guide on the National Association for State Mental Health Program Directors website specifically focused on peer support and participatory decision making. So if you're interested in that, there is a significant group of folks all kind of asking that same question. So we'll try to connect you into that. Let's see, looking for ways, so we're looking for ways for people to stay with their current providers as opposed to public, correct? Elaborate, please. I think this is a program development question, and I guess what I would say to that is more generally that we're trying to find ways for people to be able to access the appropriate care regardless of their insurance status. Generally speaking, these services are provided directly by an integrated team, and having primary providers or folks who are providing significant care off of the team can be a problem where people end up either having fragmented care or inconsistencies around the approach. So generally speaking, our experience has not been fantastic with having providers who are not part of the team. So again, that's something that can be discussed further. You really need somebody who's going to be willing to operate as if they're part of your team. So that means they have to have basic training, they have to be communicating with you, sharing your treatment plan, acting as if they're a member of your team, and that's often difficult to get with an outside provider. Let's see, is there any guidance on eligibility criteria for new first episode of psychosis high-risk programs? Thank you. In our implementation guide, there's, again, on the NASHPD website, the National Association of State Mental Health Program Directors, there is a guide that we wrote that is that includes a whole section on eligibility criteria, and it walks through some of the core questions that you need to ask about what your eligibility criteria is going to be. If you're going to include psychosis risk syndrome, first of all, you need to be sure that you've got the appropriate funding for it, because there are some restrictions from the federal government around the use of their funds. But also, it's really critical that your team be trained in the use of the SIPs, and that's really something that that Yale does. Barbara Walsh. So it's a structured interview for psychosis risk syndrome, and you really shouldn't even consider integrating high risk until your team has been trained in the use of the SIPs and understands the different syndromes, so that then you can decide which of those syndromes you're going to incorporate and at what level. So, in terms of first episode, there are a number of questions about, who you're going to screen in or out. Also questions about age, questions about, whether you include folks with developmental disabilities, that kind of geographic criteria, that kind of thing. And again, we have a whole kind of set of questions to guide you through that in our steps and key decision making in key decisions in implementing early psychosis programs. So let's see, we have a suggestion for future webinars about how states are implementing the set-aside. And fortunately, there are a number of folks producing webinars, so we'll share that suggestion. Let's see, what programs are using bundled payments and case rates? We've made an effort to go down that road here and have run into some challenges. So I think at this point, it's primarily a theoretical thing, and so we'll put the word out there to see if anybody's actually managed to get past the theory versus the practice. Is there a way to differentiate between people who are psychotic because they chronically use K2 and FEP? So let's see, that I think that would be a substance use question. And again, I think Ryan's response earlier applies there. We don't screen people out because they're using substances, but if it really looks like that's the cause, then we will screen them out. And there are some differences in presentation that are fairly significant. So we can share kind of the document we use in our training that kind of walks through some of what some of those core presentation differences are. But it looks like there's a lot of interest in this group in differential diagnosis. So we'll see if we can get that information out to folks. So we're going to probably run short of time for answering all the questions, but we will send out responses to every question that we've gotten. Let's see, how can the general community learn more about EASA? Again, we have a website. We have a 2-page fact sheet if people are interested in it. We can post that. Yeah, it's not just EASA, it's all of our programs nationally, because it's kind of a national effort right now.
Tamara, would it be helpful if I just put the easacommunity.org URL in the chat box?
Yep.
So I'm just going to
absolutely
chat over the URL to you all.
And that goes into the next question, which is there a list of existing programs that can be contacted? We do have a national directory that we are continually updating that has every program that we know about. And if you know about a program that we don't, please let us know so we can add it to the directory. That is on our website. And then again, I mentioned the Partners for Strong Minds. They also update theirs, and we share information whenever we get a new one, and vice versa. Let's see, any evidence supporting expressive art therapies? I haven't heard anything about that. But our occupational therapists certainly use art a lot. So that I'll do a little bit of looking into that to see if there's anything that is out there that just isn't being discussed.
Tamara, I have again, I have articles on effectiveness of art-based therapies with schizophrenia. So again, I have resources around that. Again, I can respond individually around that.
Okay, great. And then the question about what about folks who are, let's see, how can we get to the place where families can stay involved in care after age 18 when youth begin to not sign consent? Boy, we sure have a lot of experience with this one. And actually, it's been a lot easier than people, I think, anticipated, except there are situations where it's a challenge, but I think a lot of it has to do with how you present things. And so again, that's one that could be a whole webinar in and of itself, and we can send some suggestions to you. Okay.
And I'm noticing that we're at 11 o'clock, so I'm sorry we don't have time to answer all the questions in this format, but we will certainly get to them later on, probably via email. So I just wanted to make sure we did get some questions about keeping in touch with you. Tamara, if you just want to say your email address one more time.
Sure. It's tsale, S-A-L-E, @pdx.edu, and that is in the PowerPoint as well.
Yeah, and so, Ryan's is rymelton @pdx.edu.
Right.
Great, and I've got displayed here where you can find the slides later. It's at the Pathways RTC website, www.pathwaysrtc.pdx.edu, webinars-previous, and we'll also try to put together maybe some of these comments and questions into a fact sheet that we can upload with the webinar slides. And with that, I just wanted to thank Ryan and Tamara for their time, thank all of you for attending, and if there are no more comments, we'll call it a day here.
Thanks, everybody.
Thank you.